Yeah, let's see the medicine recall in paper 2. First is the murmur of HOCM is best differentiated by. They gave a clinical scenario and they've asked like how which manner can be done to differentiate it. First is Valsalva versus hand grip. See in Valsalva in HOCM, what happens is there will be a septal hypertrophy causing dynamic left ventricular tract outflow obstruction. So here in Valsalva maneuver, what happens after doing it? There will be decreased left-sided filling. So the obstruction will ultimately increase, causing increase in the murmur intensity. Whereas after hand grip, your afterload will increase. If afterload increases, the gradient between the left ventricular outflow tract and the aorta, this will automatically reduce. So now the obstruction is not that much and the murmur will decrease. So only maneuver which increases the murmur of HOCM is Valsalva maneuver. In a 34-year-old patient post-ileal resection, all of the following are possible except A. Subacute combined degeneration of spinal cord, B. Rhomboxine positive, C. Microcytic hypochromic anemia, D. Reversible dementia. So ileum is a site where B12 is absorbed. B12 actually is responsible for your myelin sheath formation. So B12 deficiency will affect the heavily myelinated fibers in your spinal cord. Two heavily myelinated fibers are there. Among the sensory tract, it is the dorsal column pathway, and among the motor, it is the corticospinal tract. So this is sensory and that is motor. Sensory motor. So it is a combined degeneration of spinal cord happening in a subacute manner. So if this dorsal column is affected, there will be ipsilateral numbness, tingling sensation, and rhomboxine can be positive. And if corticospinal tract will be affected, there will be human features in the affected limb. B12 deficiency will cause macrocytic anemia, not microcytic anemia. So that is the option. Erythromycin with which of the following drugs causes QT prolongation and torsade de Pontis? The answer is the antihistamine, which is estimizole. Drug to prevent alcohol withdrawal seizures in alcoholic. The answer is a benzodiazepine, which is lorazepam. Next, a growth hormone analog in treatment of HIV associated lipodystrophies. See, they have asked the growth hormone analog. If you see A tesamorelin, B bromocriptine, which is a dopamine agonist, C octreotide, which is a somatostatin analog, D mecasermin, which is a insulin-like growth factor analog. So tesamorelin is the answer. Female with pallor, weakness and easy fatigability, MCH was low, 55, TABC was 550, increased, RDW is increased, diagnosis iron deficiency, anemia. Next, a patient they have given with breathlessness and heart rate 130 per minute, BP 130/90, X-ray given features of a money bag appearance, which is pericardial effusion, and echo suggests of right atrial diastolic collapse. See, these are markers like dilated IVC, the RA or RV, diastolic collapse is there. Then the patient needs urgent pericardiocentesis. That is the answer. Next, in JVP, two questions are asked. One is absent A wave in JVP. It is due to atrial fibrillation, where there won't be any effective atrial contraction. Next is prominent or giant A wave was asked. It can be seen in tricuspid stenosis, where the atrium contracts against the stenotic tricuspid valve, or in pulmonary hypertension or pulmonary embolism, where the RV pressures will be so high, right atrium will be contracting vigorously against this high pressures, causing prominent A wave. Or if there is canon A waves, it can be regular or irregular. If it is irregular, it is seen in complete heart block, where there is atrium and ventricular dissociation, and in PSVT, where the atrium and ventricles at one point they will be contracting simultaneously. They contract against each other, producing a vigorous A wave, which is the canon A waves. I think in exam they asked a giant A wave, and options I think what I got was pulmonary hypertension or pulmonary embolism. Some features of right ventricular hypertrophy answer will be the most appropriate in this. Next, most common cause of death in idiopathic pulmonary fibrosis is respiratory failure. Due to type 1 respiratory failure, the patients often die here. Next is pediatric ECG was given, 2-year-old child, and they were asking like vitals were stable, what to do next. ECG was suggestive of tachycardia. Then next is it is a narrow QRS and a regular rhythm with absent P waves. It is PSVT. So first is obviously cardiogenic massage, but options were either to go for DC cardioversion or adenosine dose they have asked. Adenosine usually in adults we give 6 mg. So take it as approximately 60 kg adult. So 0.1 mg per kg. This is the usual dosage. So answer is always 0.1 mg per kg IV. Next, ECG was given, I think, suggestive of atrial fibrillation with heart failure. And they asked the false statement. Cardioversion is indicated if unstable. Yes, it is the ideal treatment of choice if instability, hemodynamic instability. IV digoxin for rate control, yes, and anticoagulation needed. Next is beta blockers and calcium channel blockers can be given. Or I think they have asked like if calcium channel blocker can be given, beta blocker can be given. See, the treatment of atrial fibrillation, we discussed it. If hemodynamic instability, it is always DC cardioversion. If hemodynamic is stable, then if it is a first episode or young patient or low atrial fibrillation, then you can go for rhythm control first. Or in rate control, if there is LV dysfunction or heart failure, first drug should be given as digoxin or amiodarone. If there is no LV dysfunction, then only you should go for beta blocker and calcium channel blockers. So in this question, correct answer should be beta blocker and calcium channel blocker options. Next question, a dengue patient was given with maculopapular rash and they have asked the best prognostic marker for it. The answer is nothing but hematocrit, because this is the only parameter we see in the treatment guidelines. If you see, only with this our entire treatment guidelines is based. So obviously best prognostic marker is hematocrit. Next is they've asked a patient having ipsilateral facial palsy with contralateral hemiparesis and with horizontal gaze paresis. What is the syndrome they have asked? See here, if you see, Pontine syndromes 2 foveal middle locked in. Foveal means only facial with contralateral hemiparesis, and millardogular means two things, 7 as well as 6, abducens as well as 7th nerve with contralateral hemiparesis, and locked in top of basilar artery occlusion leading to complete quadriplegia, locked in syndrome. So here if you see, there is facial palsy, hemiparesis and horizontal gaze paresis. This sets with foveal syndrome. Next question, this diagram was given. This is nothing but esophageal varice. Next one, this X-ray was given and a patient with fever, and they have given foul smelling sputum and cough. So here X-ray can see a clear air fluid level and a thick walled cavitatory lesion. Obviously the answer should be lung abscess. Next, pheochromocytoma, the correct statement is, it is bilateral mostly, no it is unilateral mostly, highly malignant, seen in men 2A, most common in children. It is seen in men 2A, that is the correct answer. It is unilateral mostly and it is seen in adults. Next is farmer on maize as a staple diet develops rash on face, neck and hand, which is nothing but niacin deficiency. Next, a drug used in the management of hyperlipidemia, patient developing facial flushing, which is nothing but nicotinic acid, which produces hepatotoxicity as well as flushing due to prostaglandin induced and macular edema too. Next is patient with tall stature, long digits, long arm span, ectopia lentis, genetic defect seen in fibrillin 1 defect because of due to Marfan syndrome. Next is a 50-year-old hypertensive male having features of aortic dissection. They have asked like stabbing or tearing type of chest pain. Troponin was negative and patient died. Mechanism behind this they have asked, aortic dissection, nothing but cystic medial degeneration. I think option was given like connective tissue weakness. This will be the most appropriate answer for this question. Next is a Stanford type B aortic dissection picture was given, which is post after the origin of all three main vessels there was dissection. So here the obvious answer is medical management only with antihypertensives like short-acting antihypertensives like esmolol. Next question, PR interval of 0.21 seconds Diagnosis. See, normal PR interval is 0.12 to 0.20 seconds. If it is more than 0.2, it is first degree AV block. If it is a fixed and a prolonged PR interval of more than 0.2, it is first degree AV block. Answer. Next, patient with macroclausia, frontal bossing and features of acromegaly was given. Initial investigation of choices, screening of IGF levels. Next, craniopharyngioma, visual field defect they've asked. Yes, in visual pathway, the rule is in the field of vision, nasal side of vision falls on the temporal hemiretina, whereas temporal field of vision falls on the nasal hemiretina. These fibers, next rule is nasal fibers cross over to opposite sides, whereas temporal fibers don't cross. They go to the lateral geniculate body, then to the cerebral cortex. So here if you see the nasal pathway traveling and temporal pathway traveling here. If there is a craniopharyngioma, which is a defect seen in the midline structure, pituitary. So what happens is this nasal pathway, this nasal fibers are selectively damaged here. So what will happen? The corresponding temporal field of vision will be lost. This causes bitemporal hemianopia. This is the classical visual field defect seen in craniopharyngioma. Thank you. Best wishes.